The Wednesday Hot Brew of
Recording in progress.
This is our fourth Wednesday of every month program, and we try to bring you a very interesting topic in various aspects of science. Today, we have two very interesting speakers who are masters in their field. We have Dr. Sujoy Ghosh and Cheryl Salas. So we will be talking, the entire focus is going to be on type 1 diabetes hands-on. These are practical topics that we would love to explore, and these are something which we can implement as doctors, as educators, and as people living with type 1 diabetes. This is our entire team from Idec here, Dr. Sanjay Agarwal sir, Dr. Neeta Deshpande, Dr. Anjali Bhatt, and Dr. Shilpa Joshi. Dr. Nitin Kapoor is with us, but he could not join for some reason. This is our entire team, and we are always trying to bring you good science. Hope you enjoy today's program, and it's a pleasure to introduce my first speaker. Dr. Sujoy Ghosh is a professor of endocrinology from Institute of Postgraduate Medical Education and Research Institute, Kolkata. But more than this introduction, he is for type 1 diabetes. I would say he is a champion for type 1 diabetes work, because the West Bengal model is now something that the world is talking about. And he is one person who wears two caps when it comes to type 1 diabetes care, and that is the district hospitals, the government hospitals, as well as private care. So he's very well versed with both aspects of it. And creating a model that a working model in district hospitals, all of us can imagine how difficult that would be. And with that effort, there is a lot of progress in getting type 1 care into the national mission, as well as the non-communicable disease program of central government. So these are big steps happening, and through big people here, over to Dr. Sujoy Ghosh. He is going to take us into a sort of interpretation of the glycemic tests we do for type 1 diabetes. We do a lot of tests. We talk about SMBG, we talk about CGMS, we do them, but do we interpret them right? And I think that is the practical aspect that Dr. Sujoy is going to take us through. Over to you, Dr. Sujoy.
Good evening, and thank you very much for that kind introduction. And thank you, Team Idec, for having me on this program. Let me try and share my screen. Hopefully, my slides are visible now?
Yes, very much.
Right.
Perfect.
Okay. So this essentially, if I'm talking about, is, in my type 1 diabetes clinic, I have a fat diary. So whoever is seeing patients in that clinic, anything and everything that he finds is interesting and exciting, he tends to write things down there. So that's my book of lessons learned. So, basic things like interpretation of a SMBG chart, interpretation of an HbA1c graph, interpretation of an AGP, a CGM, a fructosamine test, all of that is there. And hopefully someday I'll be able to write a book, hopefully, on it. And I do understand that most people who look after patients, whether it's type 1 or type 2, we are all first looking at glucose readings charts, then maybe A1Cs, and then beyond. Because I have only about 30 minutes, I will first try and cover SMBG only. And if I have time, I'll go on to A1Cs. I'm not very sure that, there's any scope for the other tests of glycemia. So what I'm going to talk to you about is entirely what I have seen myself. It's something that we've documented ourselves, and this is not from, picked up from any textbook. So it's entirely a case-based bit on, firstly, home glucose monitoring. So the first is a 14-year-old girl who's had type 1 diabetes since age 12, is on basal bolus insulin, has an A1C of 8.5, which often we in our type 1 clinics, particularly those who are not that well educated, where things aren't going that well, even an A1C of 8.5 sometimes is acceptable, and has not had major hypos. And this is what the child came with. So if you look at, say, 12th of April-ish, the blood glucose was not that bad. Then all of a sudden, in 3 or 4 days, the blood glucose starts worsening. And even on the 14th, she had no symptoms. But then on 15th, she says she's not feeling well. She's febrile, has dysuria, nausea, vomiting, and not eating well. We admitted the child and diagnosed a UTI, treated with fluids, insulin, antibiotics, and recovered. The lesson that I want you to think of here is that anytime the blood glucose goes up, suddenly one of the things that you got to think of is infections. And a lot of times, initially, the rise in blood glucose might be the only thing that might happen without any symptoms. And this needs to be managed aggressively initially at home so that the child does not go into ketoacidosis. So we follow the mnemonic of SICK. That means if a child is unwell, you'll be checking the sugars more frequently. You'll be continuing to take insulin and take even supplemental insulin and never omit the basal insulin. The C is for carbohydrate intake and increase the fluid intake. And K is for ketone testing. So any intercurrent infection will worsen glycemic control. The next is another 16-year-old girl who's on a basal bolus therapy, and the control has been pretty good, and was diagnosed with juvenile rheumatoid arthritis since age 10, has had pain and swelling and redness of the knee joint on and off, which has worsened recently, for which she has seen a specialist for the same. And she comes in with a blood glucose reading like this. In this, I want you to actually look at the pattern of the blood glucose charts. Say, for example, on the 26th of January, the sugars are relatively lower. The next day, it is slightly higher. The next day, again, it's gone down lower. And again, on the 29th, it's gone up higher. So you have an alternating day of rise in blood glucose. So the key here was that this child was on alternate day steroid therapy, which is often given in juvenile rheumatoid arthritis. Not that I want you to figure out that, the sugars are high because on alternate day. But what is important to again remember is when you're looking at the blood glucose chart, think of what else the child might be on, what other drugs might have been added, which might actually worsen glycemic control. Moving to the next, you see here, we find a child who has variable fasting glucose. Now, remember, this can be part and parcel of normal type 1 diabetic individuals. They do have variable fasting blood glucose levels from day 1 to day 2. But one of the things that we often forget is we forget to ask the time at which the fasting was done. For example, on school days, the fasting might be done on a particular day. The day the child goes out even for tuitions or maybe swimming lessons and things like that, wakes up earlier, and on other days, the child wakes up later or does the fasting test later. So particularly for the fasting reading, it is imperative that we ask the child, particularly when it's highly variable, that please not only should you be writing down the reading, but also the time when you took that reading, because that might actually tell us what the real story is. Now, this is again someone, if you see, in the month of September, we can see there are only 2 readings, which are not that bad. And then suddenly in the month of October, things have gone wrong. Now, remember, every case that I'm discussing can have multiple options of why things have gone wrong. For example, in the month of October, it could very well be that the child has an infection at this point of time for which actually things have gone wrong. But more importantly, remember, in Bengal, in the month of October, you have Durga Pujas. So things have actually gone wrong because the care hasn't been great during the Durga Puja vacations. There'll be other kids who will come back during the Durga Puja vacations who've not even documented a single reading. So monitoring has been stopped altogether. So that's, again, one of the things that might happen. We've got to keep on discussing that. Even if you're fasting, even if you're feasting, please look after yourself. Please make sure that you have an adequate diet. Please make sure you have an adequate glycemic control. We need to re-educate the patient as well. This is a 16-year-old girl, reasonably well-controlled, compliant, sensible, adjusts insulin doses and adheres to dietary therapy. Now, this girl is about 16-year-old, a Muslim girl, comes back to the clinic. And what I want you to look at is the blood sugars have started dropping very low or lowish. Of course, there are so many reasons for low blood glucose. You can say renal dysfunction, hypothyroidism, hypocortisolism, and other things. But one of the things that this girl taught me was that however young a girl is, I should be talking about contraception to the girl, and I should be talking about preconception counseling. The parents had got the child married off since the last visit, and the girl's come back pregnant. Remember, in the first trimester of pregnancy, the blood glucose can actually drop. This is because of increased renal clearance of glucose in early pregnancy, and the fasting and the glucose-stimulated insulin concentrations in pregnancy, even in a type 2 rises, and even in type 1s with variable levels of insulin, even that small change can actually make things bad. And of course, the nausea in the first trimester might decrease food intake. So first trimester, the blood glucose readings can actually go down. So 2 lessons from there. Now, I've tried to show you what the normal blood glucose pattern in pregnancy normally looks like. Now, this girl turns up later and at week 24, and we find that the sugars have started increasing significantly. Now, you've got to remember that the placenta produces a few hormones which are relatively bad for the glucose metabolism, increases insulin resistance, and that's the reason why this girl is actually having rise in glucose levels at 24 weeks. Of course, other things, like I said, infection, liver dysfunction, and things like that also have to be considered. So she's essentially having almost a feature like double diabetes. That means she's had type 1 diabetes. Now there's an overlap of insulin resistance because of increasing placental hormones. This girl, we adjusted the doses and things were fine. And then at around 32 weeks, again, her sugars start dropping. Now, when such a thing happens, the first thing that you think of is fetoplacental insufficiency. Remember, if the placenta doesn't work very well, it will not produce those hormones which were actually pushing the glucose up. So at least in the latter half of pregnancy, if suddenly the insulin requirement goes down, think of fetoplacental insufficiency. That is a warning sign for us as doctors. So after admissions, her blood glucose readings the day after shot up again. My resident called me up to say, sir, suddenly the blood glucose levels had gone up. What he hadn't realized was that the gynecologist had given the patient betamethasone for lung maturation, which actually we need to know the child will need about 20 to 40% increase in insulin dose requirement for the next 48 to 72 hours. And immediately after the expulsion of the placenta, the requirement will again drop because that bit of the insulin resistance is gone. Now, this girl came back 2 months postpartum, again with low sugars. Now, don't tell me she's pregnant again because we've counseled her well enough. What we found at that point of time was that she essentially had a postpartum thyroiditis. Now, remember, type 1 diabetes being an autoimmune disorder, the likelihood of autoimmune thyroiditis is pretty high. And that's, again, an problem that we need to remember. And the prevalence varies anywhere between 2% to 16% in type 1 diabetes. And that's the classical course. I'm not going to waste my time on that. The next is a 6.5-year-old girl who goes to school, usually is reasonably okay in terms of the glucose readings. On the Friday, however, the child actually faints in the playground. The teachers panicked and brought this child to the emergency for admission. Essentially, what had happened was one of the teachers was on leave and they had an unexpected extended lunch hour and play, which actually led to the hypoglycemia. So essentially, again, it's a reminder that if you don't take enough calorie intake, or if your physical activity is more than usual, you might have a hypoglycemia. The other thing that can happen is it might not be an immediate hypoglycemia. It can also be a delayed hypoglycemia that we need to remember. Now, this is a 12-year-old girl. And you see, on the 12th and the 13th, the sugars were reasonably okay. But on the 14th and the 15th, things have suddenly gone wrong. I've already discussed several of the other possibilities in the past in terms of infection and other things. But here, there was something else that went wrong, which is often the case in a country like India. So in India, we have 2 different kinds of insulin syringes, the 40 IU syringe and the 100 IU syringe. The difference in the dose is 2.5 times of the same. This child, unfortunately, her parents went and bought a 100 IU syringe and she was taking the same dose as per the markings, but essentially she was taking 2.5 times less insulin. And that's the reason why the blood glucose readings have actually shot through the roof. This slide doesn't seem to move. I'm sorry, the slide is not moving.
Try right click and next.
It's not moving. I might have to restart.
Okay, no worries.
You're audible now.
So my slide is not moving.
Oh, okay. Correct.
Just give me a second. Let me try and see if it moves now. I'm sorry for that. A 17-year-old boy who actually came to our clinic for the first time, was going from one place to another. Again, here you can see that there's highly variable fasting blood glucose values. So this boy was actually injecting insulin intradermally. So the technique was wrong, which was the reason why there was variability. This is another patient that you can see where the technique is grossly wrong. This is another patient taking it wrongly. So we actually published some of that data in faulty technique and how it can cause localized insulin allergy as well. Now, believe it or not, this is someone else. This is actually, the child and its parents can't read or write. So the neighbor has actually written this down in the blood glucose charts. And this is the code of the glucometer. As you can see here, the code is 233, and this is what has been written down in the glucometer chart. This is again someone, however silly it might seem, this is what comes up when you turn on the glucometer, which has been actually written down, the calibration before the reading. So we actually wrote up an article to say what a glucometer in terms of what does a child need or a kid need. Why can't it be in a local language? Why can't it be a talking glucometer to tell the readings? Right. The next year is a 12-year-old girl who's actually gone on a school trip. So this is the first time she's gone out of home, unsupervised from the parents. She has been taking Actrapid 4 units 3 times a day and Insulatard. She's on a split mix insulin. So she mixes it actually at home. Her mother actually was mixing it for her. And this is what the glucose readings are. So you can see all the pre-meal readings on the 14th are normal or less than normal, whereas the post-meal readings are sky high. So what she's been doing wrongly is, you can see on the left-hand side, this is her Actrapid. This is what the normal Actrapid looks like. You can see this has gone hazy. It's because the NPH has gone onto this insulin vial of Actrapid, and which has converted the short-acting insulin to a long-acting insulin because of wrong mixing techniques of the split mix regime. Now, this is again a child this is directly from the logbook, where you can see the blood glucose readings are wonderful and the HbA1c is 12. So, of course, it could be that, in the past things were not great in the last 2-3 months, and maybe things have gone wonderfully well when the child has actually taken the reading. But what I learned in the hard way was the child was only writing down the good readings and not the high readings. And this is something that we've often found that the child does because the child is scared of the parent, that the parent is going to scold the child if the sugar readings are high. I have seen in cases of small kids, the mom fudging data because she's worried that once the father comes back home, he's going to scream at the mom. So we actually, and this is, for example, another child claiming that he has actually checked 6 times, 7 times a day, but it's a small child who doesn't know how to fudge data very well. So essentially, has ended up writing all the readings ending with 0. And again, this is again another reading where you see there's almost a pattern in which the child has actually checked blood glucose. In all of this, we actually went and did an audit of cross-checking the data that they're writing down on the glucometer in the logbook versus what's actually there in the glucometer. And we've realized that reliability is a huge issue. And why I'm saying this is because we've now made it a point that every time we see a child, we cross-check the data. And there are many reasons why this happens. And some kids will even take the battery out so that the memory goes. So there are some glucometers where you can't get rid of the memory that easily. So those glucometers might actually be better. So what I've tried to highlight here in this, say, 20 minutes or so is the variability. So it could be infection, drugs, onset of puberty, pregnancy, missed doses, teenage tantrums, situationals, festivities, embarrassments, so not taking the insulin, inconvenience of not taking it, run out of insulin, problems of storage, skipping diet, unaccustomed, unforeseen exercise, problems with insulin syringes, injection techniques, glucometers, and of course, fabrication. So I'll quickly go through to the second bit of my presentation, and I'll skip some of the slides because these are mostly technical bits. I'll go straight to cases to look at interpretation of HbA1c and what goes wrong there, because I think I have about 5-10 minutes more. So a few clinical cases. So this is case number 1. I don't know whether you can see very clearly what I've highlighted here. If you see, many of the doctors actually don't know how to interpret the HPLC graph. So I'm just going to try and show you. Here it's written A1C, just at least imagine. And here it says it's 20.1. Now remember, every machine that checks HbA1c, the HPLC, has a linearity. That means it has an upper level of measurement as well. So the Biorad D10 machine that has actually done this can measure only up to readings of 18.5. It's like you've got a weighing machine which has the capability of weighing up to 100 kilograms. So can it give a reading of 110? Obviously not, because it then becomes unreliable. So knowing the upper limit of the A1C machine's limit that you are using, excuse me, is important because it tells you what is right and what is wrong. So the Biorad D10, which most of us use, has a cutoff of 18.5. Now, the other things that we often don't look at, this graph is perhaps better. You see there's something that I've highlighted, which is the S window. So HbA1c is 7.4 here, so you must be very happy. But if you see A0, which is the normal A1c, is only about 50.6, which normally should be above around 90%, because that's 90% of the A1c will be non-glycosylated. On the other hand, you have an abrupt S window that comes up here, which essentially is a sickle cell variant. So this variant is there of 38%. Therefore, this A1c of 7.4 is actually not interpretable. So do not use an HPLC, use alternative methods of interpretation of A1c. Here again, you can see another variant window, which is 40.4%. Therefore, this A1c of 6.8% is not correct. There are many more cases of hemoglobinopathies. In this one on the left-hand side, if you see, it shows 0.0%. Particularly in eastern part of India, hemoglobin E disease is very, very common. And if somebody is homozygous for hemoglobin E, his A1c will come back as 0 because it elutes at the same point where HbA1c elutes. Now, these A1c machines, at least some of them like the Biorad machine, has got two modes. One mode checks the A1c and the other screens for hemoglobinopathies of thalassemia. So the moment you have a variant window, the lab should actually run the A2 mode. And here you can see the A2 mode tells us that the peak is at the area of the hemoglobin E disease. So straight away, this is wrong in terms of interpretation of hemoglobin A1c. Now, if you look at this one, I don't know whether you can read, the F you can see, which is the fetal hemoglobin, has come back as 15.5. So again, if the fetal hemoglobin level is high, you cannot interpret HbA1c values. So here I've tried to summarize. If anyone's bilirubin is more than 20, the A1c assay is wrong. If the triglyceride is more than about 5,500, it's wrong. Fetal hemoglobin concentration above 10 gives you wrong results. And I'll come to labile and carbamylated hemoglobin in subsequent cases. So here you can see someone who's got an HbA1c of 2.47, a type 1 child. Now you will think, oh, the blood glucose control must be great. What we often forget to understand is, don't look at an HbA1c on its own. Look at the hemoglobin as well. This is someone who had a rupture in the gut and needed an anastomosis, lost a lot of blood, and has had a transfusion. So the hemoglobin is too low, and a part of it is not his own hemoglobin because he's got an RBC infusion. So this HbA1c of 2.7 is actually erroneous. So there are other reasons why A1Cs can be inappropriately low or inappropriately high. Always keep that in mind, including drugs, which can either increase A1Cs or lower A1Cs. Now, this is a very interesting case. Actually, I traced the family of this kid way back to Kerala. So you can see the hemoglobin A1C is 54.2. So this is a hemoglobin variant which is common in Kerala as well. This is a Keralite child whose parents were posted in Kolkata. This is called hemoglobin hope disease. So you can see the variant is 42.8%, which we don't, this A1C is 54.2%. We don't know where it's come from. If you ran the A2 mode, you would have gone, what is the hemoglobin hope variant? Now, this is again another variant window where you can see it's 53% variant. We ran the A2 mode and it turned out to be hemoglobin D Iran. This is again a much more weird variant where we actually did genetics to figure out that this was actually alpha thalassemia. We did the genetic mutations for the same, but something more common. So this is someone who's a 25-year-old who's gone into chronic renal failure. Now, I told you there's another column that comes up in that graph, which is called LA1C and CHB. So this is labile hemoglobin or carbamylated hemoglobin. In chronic renal failure, the carbamylated hemoglobin increases dramatically and interferes with the HbA1c assay, and therefore this A1c of 5.1 is wrong. And again, a case of persistent fetal hemoglobin, and 18-year-old has come in with a history of menorrhagia on basal bolus therapy. The fructosamine results are not that bad, but the HbA1c result is very poor. Now, you've got to remember that when you have anemia, particularly iron deficiency anemia, the red blood cell lifespan is no longer 120 days. It is prolonged because the body is trying to preserve whatever RBCs you have. Therefore, this RBC is exposed to glucose levels for a longer period of time. And therefore, there is greater glycosylation, as a result of which the A1C will be falsely high. So I think I've tried to cover most of the things. And one of the things that we always need to remember is that communication across disciplines is very important, because, whenever we get a report that we can't interpret, we scream at the biochemist and tell him that he's got it wrong. Essentially, he doesn't have the history. You don't know the basics of biochemistry. So crosstalk is important. History and background of the patient is very important. Unexplained report does not mean that the report is wrong. And it's okay to say that I'm uncertain of the results. And I will admit, of all the millions that I've seen where I could not find a reason, I've only found reasons in these few of why things went wrong. And that's the reason I'm discussing these with you, so that others at least get this right. And use appropriate technology. If A1C is not giving you the right result, go for an SMBG or go for an AGP. And we still have huge knowledge gaps. Thank you very much.
Thank you so much. Thank you, Dr. Sujoy. That was wonderful. I think it was a whole new insight into raising our suspicion index, looking at the things we take for granted today, looking at a SMBG and a HbA1c in a very, very critical scientific light. And as you went through each case, I could think of every single case that I have been seeing, and it's so much similar, and we have lots of questions for you, but we will come to that in the panel discussion. We will have a second speaker first now, and Cheryl has joined us. Cheryl, you're here. Yes,
Yeah.
welcome, Cheryl. So our next speaker is Cheryl Salis, a very dear friend. She is a nutritionist, diabetes educator, and a pump trainer. She's also author of a beautiful book called Diabetes Simplified, one of my favorite books, which I recommend to everyone to understand carb counting. She represents India in ISPAD, and we are very proud of that. And she is going to talk to us about the latest trends in nutrition in type 1 diabetes. And after her talk, then we'll have a very interesting panel discussion with Dr. Sujoy and Cheryl. Please keep your questions ready and you can post them in the box that is meant for questions. Over to you, Cheryl.
Thank you so much. And it's wonderful seeing all of you. And it's a pleasure being here. And my topic is on MNT in type 1 diabetes. And that's one subject which is very, close to my heart. And I think we both share the same passion, ma'am, that, working with children with type 1 diabetes, and just very different to working with people with type 2 diabetes or gestational diabetes. And therefore, MNT is very different for children with type 1 diabetes. And in the next 30 minutes, I'm going to take you through the advances in MNT in type 1 diabetes. So I'll just give you the outline for my talk: macronutrient recommendations in type 1 diabetes, carbohydrate counting, synchronization between types of insulin and meals. We'll go beyond carb counting because today we also talk about protein and fat counting and how do we apply it to our clinical practice. We have the ISPAD guidelines, and the latest ISPAD guidelines were released last year. And it has been my honor and privilege to be a co-author with all other dietitians across the world working in the area of type 1 diabetes. And it was a wonderful experience representing my country and sharing, our experiences with our patients. And today, when it comes to type 1 diabetes, we follow the ISPAD guidelines. What are the goals of medical nutrition therapy in type 1 diabetes? To ensure normal growth, development, and maintain healthy weight and BMI. I think this is the most important thing, because when the child is diagnosed with type 1 diabetes, the parents are, it's like an earth-shattering moment for the parents. And often they wonder, now what do we, give the child? And there's a lot of restrictions that come in, and parents often, compromise on the nutrition because they're chasing the blood glucose numbers. But it's very important to tell them that these children need the right amount of nutrition, calories, protein, and all other macro and micronutrients because they need it for their growth and development. To match food intake with the insulin action profile, and we're going to discuss this in detail in the slides to follow. To have a desirable glycemic control over the day, and yes, when we're looking at HbA1c, we're also ensuring that the child does not experience hypoglycemic episodes and is at least 70% of the time in range. And today, thanks to CGMS and technology coming in, we are able to achieve a good glycemic control and give more flexibility to the children when it comes to food. Minimize short-term and long-term complications. And again, with children with type 1 diabetes, we do see hypothyroidism and celiac disease as well. And therefore, it's very important to modify the meal plan if hypothyroidism or celiac disease is, a comorbid condition along with it. Now, again, when it comes to children with type 1 diabetes, when they present to us, after most of the time they are diagnosed in the hospital, in the ICU with diabetes ketoacidosis. And when they are discharged and when they come home and are referred to us in our clinic, we do a thorough assessment. One is we definitely look at the growth chart. We look at what is the kind of weight loss that has happened during the diagnosis. We do an assessment and dietary recall of even what they were consuming, because, when they are diagnosed, there's a lot of restrictions that come in. Parents do not know what to give the children, and there are very limited options that they would give children. But we try and understand what was their food habits and their food pattern before diagnosis. And this is extremely important. We also tell the parents to list out, give us a list of things, the favorite things of the child, so we can incorporate it into the meal plan, and therefore trying to bring back the joy of eating in the child's life. We calculate the energy and nutrient requirements, principles of healthy eating. I think this is extremely important before we go on to carb counting, because most often we receive WhatsApp messages from parents and children saying that, okay, I'm eating a pastry, or I'm eating a gulab jamun. How much carbs is it? Because they think it's very simple. You just take insulin for the carbs. But very, very important is to tell them that all children, whether it's a child with type 1 diabetes or without type 1 diabetes, needs to a balanced, healthy diet, because that is extremely important, because we're seeing a lot of cases of childhood obesity and also childhood type 2 diabetes today. Synchronize insulin with meals, going on to carb counting, protein and fat counting, and then hand-holding them. So very important is, again, to handhold these parents, because they do not understand carbs, protein, fat. They eat food, and therefore it's very important to help them understand, which are the foods which have got carbohydrates. And then very important is also that carbohydrates are not a villain, and they should be taken in the right amounts, because it is important for their growth and development. And how do they ensure that they get good glycemic control? By eating a balanced diet. We calculate the energy requirements. Again, when the child is diagnosed with diabetes, there is a loss of weight, so we help them regain the lost weight. And again, when it comes to the calorie requirements, it is very similar to a child without diabetes of the same age, weight, and gender. And again, we take into account the level of activity, because a lot of children are pursuing different sports today. So again, that has to be taken into consideration. The energy requirements go higher in puberty, and the first year of diagnosis is a very critical period, because the moment they understand, they start applying carbohydrate counting. Some of them may misuse it and then eat a lot of, carbs and take a lot of insulin, and that results in weight gain. So again, we do not want obesity, because there is more insulin resistance, and the requirement for insulin therefore further goes up. Now, as per the ISPAT guidelines which were released last year, that is the ISPAT 2022 guidelines, the carbohydrate recommendations are 40 to 50% of calories coming from carbs. Of course, we have to look at low to moderate glycemic index and glycemic load foods. When we're looking at sucrose, that is sugar, up to 10% of total energy of sugar is allowed, and that should be factored in when we are doing the carbohydrate counting. Now, where fats were considered a villain in the past, today when we are moderating carbs and we want to meet the calorie requirements, then we increase the fat intake from the good fats, that is the MUFA fats, mostly coming from your nuts and seeds, and they become a very good addition into the diet, because when we're looking at low carb options, your nuts are a good addition into the diet, because that will give you energy. They're healthy fats, and they are low in carbohydrates. Now, again, very important when we're talking about nuts is to help them understand that nuts and dry fruits are different, because when we tell them they can take nuts, they often go and start consuming dates and raisins and apricots and figs, thinking that dry fruits are allowed. So again, very important is to help them understand the difference between nuts and dry fruits. Less than 10% of calories coming from your saturated fats, negligible trans fats, proteins 15 to 25% of the energy, and therefore, again, making sure that every meal has got protein, because protein, one, it helps to achieve satiety. It also helps to blunt the post-glycemic blood glucose response. Fiber for children is age in years plus 5 grams, and for adults, 20 grams per 1,000 calories as per the NI and ICMR 2020 guidelines. Again, the Jocelyn's food plate has become very easy for us to explain to the children in terms of, how to take a balanced diet and how do you fill your plate. So half your plate should be non-starchy vegetables. 1/4 of your plate should be your starchy, vegetables, your cereals and millets. And 1/4 of your plate should be your protein-rich sources. So by, looking at this food plate and by educating the parents and the children about the food plate, it becomes very easy for us to try and bring in, adequate nourishment into the child's diet. So focusing on this at every meal, whether it's breakfast, whether it's lunch, snack, as well as dinner. Again, when it comes to low carb options, because low carb diets, because, often we are seeing more and more cases coming and more parents coming to us and asking us that, carbs increase the blood glucose levels. So is it okay we, put the child on a very low carb diet, which is around 20 to 50 grams of carbs per day? But the ISPAT guidelines very clearly state that we should not, recommend less than 50 grams of carbs per day. So very low carbohydrates diets for children are definitely not recommended. And that is less than 26% of energy from carbohydrates. And honestly speaking, from our clinical practice, we Indians consume a lot of carbs. So, we have enough studies which have shown that Indians consume around 65 to 70% of calories coming from carbs. So just moderating to carbs to around 40 to 50%, we're able to achieve good time and range and good glycemic control. And also, help the children enjoy, different varieties and not become very restrictive, because low carb diets can be nutritionally inadequate, especially in calcium, B vitamins, iron. And most of these low carb foods have a lot of fiber. If you look at the rotis, they would have, oat bran, they would have flaxseed, they would have, psyllium husk. There's a lot of fiber which is added to the diet, which will actually impede the digestion or absorption of very essential nutrients. And often we see the, stunting of growth and also lower hemoglobin levels. And therefore, it's very important to monitor these children, speak to the parents, counsel them, understand their concerns. And, because if we are going to tell them no, they're definitely going to go to somebody else who's recommending it without realizing the repercussions of it. And there's also an increased risk of disordered eating behaviors. And if an adult wants to do a low carb diet, they're free to do it because they've, passed through their growth and development phase and they've achieved all their milestones, and it will not really impact their health if they're eating it in a balanced manner. Now, carbohydrate counting again becomes very important because, we're seeing increasingly the dinners have been replaced by snacks. So typically, if you look at India, the dinners, when we try and take dietary recalls, we understand that somebody is eating sandwich for dinner. Sometimes it's a pizza for dinner. It's a bruschetta for dinner. Though we do not encourage it, we definitely help them, modify the recipe to make it healthy because the child wants more variety. But while we are doing that, the carb content of the meal will change. And therefore, if they're going to take the same amount of insulin for their meals, they would either take more insulin or less insulin, resulting in hyperglycemia or hypoglycemia. Again, like in the past where, there was a constant fear of hypoglycemia and we would feed for the insulin, with the now modern day insulins coming in, we actually give insulin for the carbs consumed. So if the child is not hungry, for example, in the summer season, you don't feel hungry, you want to eat less, you have that flexibility of taking lesser food and therefore taking lesser insulin. Or if the child is hungry and wants to eat that extra chapati or wants to eat that half cup or 1 cup of rice extra, the child is free to do so by calculating the carbs and taking additional insulin. The children also get flexibility when it comes to going for birthday parties, for picnics, because again, we want the children to eat what would be served in a birthday party. But very important is to do the accurate estimation of carbs. You can't get 100% accurate when it comes to foods. So plus minus 20% is all right. And we basically ask the mother to ask the host, what is there on the menu, calculate the carbs for the child, and then the child will bolus accordingly. So why do we do carbohydrate counting? Because they're the main nutrients which affect blood glucose levels. Protein and fat take up to 3 to 4 hours to show as blood glucose, and therefore we see that when you eat an ice cream, it will not immediately spike the glucose levels, but after 4 hours, 2 to 4 hours, you see the blood glucose levels start to spike up because fat releases glucose slowly, and therefore it is definitely not recommended in hypoglycemia because most of the children look for hypoglycemia so that they know they can have their chocolates and ice creams or desserts, and that is not something that we would recommend when the child is having a hypoglycemic episode. The dose calculations is as per the insulin to carb ratio, which we are going to discuss. And carb counting accuracy, we try to get 100% accurate, but honestly, with our Indian foods, it's very different because each household has a different recipe of cooking the same recipe. And therefore, there's a lot of evidence to show that plus minus 20% really does not make a difference in achieving optimal blood glucose control. SMBG and CGMS definitely help in guiding decision making, and therefore it needs to be done more often. And often people think that if I do carb counting or if I go onto the insulin pump, I really do not need to monitor, but that's not true because SMBG and CGMS will only help us and give us a direction and whether we're going in the right direction or we need to maneuver. So this is again a very important point. What should carb counting include? Like I said, that parents really do not have an idea, and most of us, unless we are not in the field, we do not know which foods have got carbs, which have got protein, which are the foods which have lower carbs. It's again, we start from basics, in terms of educating them. Which are the carbohydrate containing foods? Which are the foods which have got low or no carbs? For example, non-veg foods would not have carbs, whether it's egg, chicken, fish, meat. They do not have any carbs. Nuts have lower carb content. So these are important points to be discussed with the parents and the children. Today, a lot of children eat out of food packets, and therefore food label education becomes extremely important. So we teach them on how to read food labels because most of them would say they're healthy, but when you look at the food labels, it tells you a different story. We always encourage them to buy food weighing scales and handy measures such as your cups and spoons, which are easily available. And this would help them, in terms of estimating the carb counts. And today we have a lot of resources which provide the weights of foods where they can weigh the food and then, calculate the carbs. For example, I know that if I'm eating 1 cup of rice, it roughly is around 30 grams of carbs. use of resources. We have a lot of resources available today. Practical advice about food away from home. We have a lot of children who are in hostels for further education, or they're going to restaurants and they want to know exactly how much they need to bolus when they're eating away from home. Use of insulin to carb ratio, SMBG, and CTMS. Now, these are the foods which contain carbs. So whether it's a bhakri or a chapati, it will have the same amount of carbs. People, and we're celebrating the International Year of Millets, and often people switch from a wheat roti to a jawar bhakri or a bajre ki roti or any other millet roti, thinking it's more healthier, but they need to be educated that whether it is any millet or whether it's wheat, it has the same amount of carbs, and therefore it needs to be calculated. If you look at all the different carb-containing foods, again, starchy vegetables, most often people will eat roti with potato vegetable, and potatoes happens to be a very favorite vegetable of most of our kids. But again, potato is a starchy vegetable and will have more carbs compared to a non-starchy vegetable. Pulses and dals. Often people think that dals only provide protein and do not have carbs. Again, that's a myth. If you take 30 grams of raw dal, it will have 15 grams of carbs. Again, jaggery, honey, and sugar. Most people will switch from sugar to jaggery or honey, thinking that honey and jaggery, because it's brown in color, even brown sugar for that matter, and they think it does not have carbs. But again, whether it's jaggery, sugar, brown sugar, or honey, it will have the same amount of carbs. Sweets, all, when we ask them to have yogurt, they'll go to the market and buy a flavored yogurt. Again, flavored yogurt, if you see a cup of flavored yogurt and you read the food label, it will roughly have around 15 to 16 grams of carbs. Other snacks, popcorn, whether it's makhana, which is a very popular snack, especially in the, people with diabetes. Then you have dairy. Milk does increase the glucose level because of the lactose in the milk, and it does spike up the glucose levels. Now, this is the book that I have written for ISPAD along with other dietitians from Australia. And this gives you an estimate of the carb count of our most commonly eaten Indian foods. So we've actually given the weights. For example, if you're taking a 40-gram cooked weight chapati, it will roughly give you around 15 grams carbs. One slice of bread, whether it's brown bread or white bread, will have 15 grams of carbs. We're in the mango season, and we definitely do not restrict mango or tell the people to avoid mango. We educate them on when to eat the mango, how much of mango to eat, how to eat the mango, because mango gets converted into a lot of different recipes. You'll have amras, you'll have juice, you'll have shrikand, and therefore it's very important to educate them on when to eat it, how much to eat, and what is the insulin that they would require for that much amount of carbs. And again, we are very diverse in our country. North eats very differently to East. East eats very differently to the South and, to the West. And therefore, it's very important to help, the child enjoy the diet which they are used to eating right from childhood. So very important is not to change, but to modify the recipe, yes, to make it healthy, ensure that the entire family adopts healthy eating habits and trying to stick to their traditional recipes. And they're extremely healthy as well. Again, decoding nutrition labels, because you have biscuit packets saying they're sugar-free, but it's important to educate them that they're not carb-free and they're not calorie-free. And therefore, reading the food label becomes extremely important. Now, these are your foods which have got low or no carb. Again, how much to consume. We had a patient who actually, we told them that curd has got lesser amount of carbs and, you can give curd in between. And the mother started giving 1 kilo of curd at a time because she thought curd has got no carbs. And the child was very hungry. And then we saw the glucose levels shooting up. So again, it's very important to explain to them that how much portion is, and when do you consider a food to be having lower carbs? So any food which has got less than 5 grams of carbs per serving is considered to be a low carb food. So whether it's your vegetables, eggs, like we mentioned, have got no carbs, chicken, fish, but again, that has to be in moderation because of the fat contents. We have to ensure that they're eating foods which are low in sodium and saturated fat. They can't go overboard with cheese just because it is a low carb food. Your nuts fit in very well, and this is something that we could encourage our parents. Curd, again, it shouldn't be the flavored yogurt, but it could be the plain curd, paneer, how much of it, soya bean, etc. Then we come to the formulas, which is your total daily dose. And again, carbohydrate counting can only be done when they are on a separate dose of basal and bolus. It cannot be done when they are on a pre-mixed insulin because you're taking the insulin for the carbs, and therefore it has to be when the person is on a basal bolus regimen. So basal and bolus, you arrive at the total daily dose. So for example, if the bolus is 5 units in the morning for breakfast, 6 units at lunch, and 6 for dinner, and a basal analog of 17 units, the total daily dose is 34 units. The formula for insulin to carb ratio is 450 if it's a regular acting insulin. So 450 divided by the total daily dose, and 500 if it's a rapid acting or a fast acting insulin. So 500 divided by TDD. So that will give you what 1 unit of insulin is required to cover how many grams of carbs. So 1 unit of insulin covers how many grams of carbs. For very young children who require less than 10 units of insulin per day or are less than 5 years, 300 to 450 rule may be adaptable. Again, this is not etched on stone. Children could have a different insulin to carb ratio in the morning because there's more insulin resistance, whereas in the evening time, they could have a higher insulin sensitivity, and therefore the insulin to carb ratio could be different. And SMBG and CGMS are the only ways to guide us in terms of arriving at the insulin to carb ratio. So while we are, monitoring this child and following up with this child on a regular basis, we're able to assess as to, what is the insulin to carb ratio in the morning versus what is the insulin to carb ratio in the afternoon and in the evening. And most often it would be different. Again, like I mentioned, CGMS and SMBG has done a world of a difference, and we should encourage our patients to maintain, their logbook, maintain their diary, ask them to get their glucose monitors, because some of them even would manipulate the readings, because for them, every glucose test is an examination. And therefore, we have seen people manipulate HbA1c readings, manipulate the glucose readings. So request them to get their glucose monitors with them, look at their CGMS reports, and then that will help guide us actually in terms of, what is the right thing to, prescribe, whether it's breakfast, lunch, dinner, etc. Now, when we're looking at, again, the formula, so 1 unit of insulin that we mentioned covers around, how many grams of carbs, and this number would be different. Typically, people think that 1 unit of insulin covers 15 grams of carbs, but this is not true. It could be different it is usually different for different people, depending on what is the total daily dose. So for example, in this case, the total daily dose was 34 units per day. So 500 divided by 34 is 15. So 1 unit of insulin covers 15 grams of carbohydrate. And like we mentioned, the number could vary. In the morning, if there's more insulin resistance, the child could need 1 unit of insulin, say, for 12 grams of carbs, and 1 unit of insulin for 15 grams of carbs in the evening. Now, this is another thing, which is a misconception or a myth, that eat every 2 to 3 hours if you have type 1 diabetes. Or most often people think that everybody who is on insulin will need a bedtime snack or will need to eat every 2 to 2.5 hours. And that is not true, because today you have newer insulins, and with every insulin, it will call for a different meal prescription, and what we call it as MNT, so medical nutrition therapy, or the MNT plan. So if the child is on a regular acting insulin, the meal prescription would be different compared to a child who's on a rapid acting or a fast acting insulin. So therefore, it's not a one size fits all approach. Again, every child is different, and certain foods would, impact the blood glucose levels differently in different children. And therefore, we have to work very closely with these children, keep looking at their blood glucose trends, and then take corrective action. Now, when it comes to pre-mixed insulin dose, let me make it very clear here that if you look at the ISPAT guidelines, and the 2022 guidelines have very clearly stated that pre-mixed insulin should not be prescribed for children, because that brings about a lot of rigidity. You have to have consistency in terms of meal timings. You cannot really do the carbohydrate counting, because when you're increasing one type of insulin, you're also increasing the longer acting insulin or the intermediate acting insulin, and therefore it becomes a very, very rigid kind of a regimen, and therefore premixed insulin is not recommended for children with type 1 diabetes. Now, we come across different scenarios, when it comes to our patients, and they, are prescribed insulin. So they would, come with different insulin regimens depending on how their, schedule is, their school pattern, holiday pattern, so they have that conversation with the doctor, and therefore we have, like Dr. Sujay very rightly said, it has to be teamwork. We work together. So it's it is the patient's doctor, it is the diabetes educator and the dietitian who would work together to ensure that this child, is managed well. One is that is enjoying, the quality of life is good and is also achieving good glycemic control. So when a child comes to us with an insulin prescription, whether it's regular acting insulin in the morning, regular acting insulin at lunch, and regular acting insulin at dinner, then this insulin, because of the R insulin, it has a peak. And therefore, we plan a breakfast, a mid-morning snack, a lunch. It'll also cover the evening snack, a dinner, and a bedtime snack. So here a bedtime snack would be mandatory because otherwise a child would go into a hypoglycemic episode. So depending on their insulin to carb ratio. So one is definitely we look at their energy requirements, then we do the carbohydrate, protein, and fat distribution. And then we look at what is the insulin prescribed. And therefore we would do the carbohydrate allotment, whether it's breakfast, mid-morning, lunch, evening snack, dinner, and bedtime. Now, this is another regimen where you have the child on a basal analog, which is a long-acting analog with regular-acting insulin at breakfast, regular-acting insulin at lunch, and regular-acting insulin at dinner. And typically, this is if it's a child is going to school and the child does not want to take insulin in the school. Sometimes they're prescribed this regimen, and therefore, again, this would cover the breakfast, a small snack at mid-morning. It could be a moong dal dosa or a chilla, or it could be some kind of a healthy snack. We definitely prefer a more healthier snack in the sense of a pulse-based snack. It could be a chana chaat, or it could be an egg wrap, something like that, which is, again, we're looking at, the carbohydrate distribution. A lunch, most often they will have an evening snack and then go down to play. Then the dinner and the bedtime snack. So here again, we check the glucose levels at bedtime, and then we would decide to give them the bedtime milk or whatever snack that the child wants to have at bedtime. Now, this is another regimen, especially if the child is on a rapid-acting insulin at breakfast, at lunch, and at dinner. So here, a rapid-acting insulin typically would cover one meal, which is your breakfast. If it's given pre-breakfast, if it's given pre-lunch, then lunch. If it's given pre-dinner, then dinner. Now, here the advantage is that you do not need to give a bedtime snack. You definitely monitor at bedtime. And if the glucose levels are low because the child has had activity in the day, you may need to give a bedtime snack. But otherwise, it is not mandatory to give a bedtime snack here. However, if the child is eating a snack between breakfast and lunch, you have two options. One is that you give a low carb or a snack like an egg could be given at mid-morning or in the evening, which has got no carbs and would not need insulin, or you give a snack by calculating the insulin to carb ratio. For example, if the child wants to eat a sandwich in the evening, you calculate the carbs. For example, if the child is having a sandwich which has got roughly around, say, 30 grams of carbs, and if the child's insulin to carb ratio is 1:15, then you would give 2 units of insulin. But very important is to make sure that you're not giving 2 insulin shots within a gap of 3 to 4 hours, because the action of the previous insulin is still there. And if you give an insulin shot in a gap of less than 3 to 4 hours, then there is a high chance of the child going into hypoglycemia. And therefore, again, you have 2 options. Either you give a low carb snack at mid-meals, or you give a snack which has got carbs and you calculate the carbs and give insulin as per the insulin to carb ratio. Again, very important is to keep activity in mind, because if the child is going to be physically active in the evening and has a mango, and typically we allow the children, it's the mango season, and that becomes a big motivator for the children because they know, okay, I'm allowed a mango if I go down to play. And we typically see that when they come back from play, even if they've not taken the insulin for the mango, if their sugars are good, so if their sugars are, say, 100, and if they've eaten a mango, gone down to play and come back, usually their sugars before dinner are very normal. Then this could be another regimen, again, because in the school, they do not have the facility to give insulin. So then the child could be on a regular acting insulin in the morning, regular acting insulin at lunch, and rapid acting insulin at bedtime, at dinner, because the child has had their dinner at 8 o'clock. Bedtime is 9:30. The mother it's very difficult to wake up the child in the middle of the night to force them to have that cup of milk. And therefore, this is another regimen which is very popular. So again, this will call for a breakfast, a mid-morning snack, lunch, a mid-evening snack, and dinner, and not mandatory to give a bedtime snack. So bedtime snack is not required here. Now, this is what we spoke about, how do we synchronize the meals with the insulin that is prescribed? And then comes that, okay, I have taken insulin for the carbs, but even then my postprandial blood glucose levels are not in the range. For example, I've had a moong dal dosa or a chilla, the glucose levels are very good. But if I've had a poha, I see a sharp spike in glucose level versus a paratha, the spike is quite high and it remains high for a long time. And therefore, the same quantity of carbs, but I see there's a difference in the blood glucose response. So what could be happening here? So therefore, all carbs are not the same. So we have to go beyond carb counting. And there are many, many factors that affect your mealtime insulin dose. What is the fasting pre-meal blood glucose levels? Is there insulin resistance? Typically in the morning, we see the insulin resistance could be higher. Bolus timing. Most people, sometimes they see in the hospital, the nurse has given the insulin after the meal or just before the meal, and they will go and do the same thing at home. And therefore, it's very important to educate them as to what is the right time to take the insulin before the meal. Carb counting accuracy, like I mentioned, up to 20% is fine. Glycemic index, certain foods have a higher glycemic index, and therefore we see a sharp spike in blood glucose levels. So how do I, take the insulin, to ensure that the glucose levels are maintained even if I'm eating a high GI food? The protein content, like we mentioned, that, if the person is going to have high protein, high fat meals, it's definitely going to impact the blood glucose levels, not immediately, but later on. The type of insulin, we've already discussed it. Physical activity, for example, today the child is very physically active and now exams are coming in and the child is just not going down to play. And we do see that impacts the blood glucose levels as well. Gastroparesis, stress, menses, alcohol, illness, all these affect blood glucose levels. And therefore, you have a lot of challenging foods because eating out has become very common. Ordering in food has also become very common. And how do we address this? So one is when we're looking at high glycemic index foods. For example, cornflakes, it has a very high glycemic index. And typically, even if they cover, with the right insulin to carb ratio, we see a sharp spike in blood glucose levels. So what can be done here? First thing is early preprandial insulin administration. So taking insulin ahead of time, reduce the total carb amount, so take smaller portions, add protein or fat and fiber to the meal, and consider food order. So start your meal with protein and fiber and then move on to the meal. In the pump, there is something called as a super bolus, at least in the one version before what we have now, that is 780G. We had the 740G, and which the 640G, in which you had the super bolus you could take, is basically you borrow the basal dose of insulin and you add it to your bolus dose so that it takes care of this sharp spike in blood glucose levels. Now, the American Diabetes Association 2023 guidelines, as well as the ISPAT 2022 guidelines, say that selected individuals who have mastered carb counting should be educated on fat and protein gram estimation as well. Now, what is the effect of protein and fat? Again, if you look at our Indian home cooked meals, and we all agree that all meals, whether even if it's non-vegetarian meals at home, they typically do not have enough protein. So we are deficient in our protein intake, most of us, and carbs still remains a challenge. So at home, mostly we do carb counting, but when it comes to eating out, for example, eating a Chinese meal, an Italian meal, or a pizza, a burger, or, Mughlai meal, which has got more amount of fat, there definitely you have to consider fat and protein. So high fat is when it is more than 20 grams per meal or more than 30 grams of protein per meal. It will slow down the breakdown of carbohydrate from the meal and it causes a delayed hypoglycemia. And typically we see that, the parents will tell us that the glucose levels have stayed high through the night and sometimes even up to the next day. And we see a fall in blood glucose level immediately post-meal, and then there is a sharp spike. And this is typically what happens even with ice cream or even your Indian desserts. And that's why we do not encourage correcting hypoglycemia with this meal. So therefore, additional dosing for meals more than 20 grams of fat and 30 grams of protein is required. But like we said, that insulin to carb ratio is also not etched on stone. It can vary with different individuals. And the same applies to fat and protein. And therefore, again, analyzing the trends, looking at it, following up with the person, monitoring closely becomes extremely important. And frequent BG monitoring as well as CGMS is recommended in these cases. Again, high fat and high protein meals, we see that, early on we see a dip and then there is a sharp spike, there's a sustained hyperglycemia between 3 to 5 hours. Again, adding protein to a carb counting meal may help prevent late post-meal hypoglycemia, especially post-activity. And that's why post-activity we always encourage protein to be added to the meal, especially at the dinner meal. Now, in the previous pumps, we had different types of boluses. And again, depending on the meal. So if it's a carb-rich meal, for example, I'm eating a sandwich, I just take a normal bolus. Whereas, in certain conditions like gastroparesis, you may want to take a square wave bolus because we do not want the hypoglycemia to happen because of the delayed release of blood glucose. And when the child is eating a pizza or a high-fat meal, you do a dual wave bolus, which is normal bolus with square wave bolus. Now, how do I manage the high-fat and protein meals on insulin pump therapy? So basically, the recent data in children and adolescents using insulin pumps say that 30% of the dose for a very high protein meal and up to 60% for a high fat, high protein meal may be required. But very important is to start small, step up gradually. We do not want hypoglycemia. And therefore, we start with 20% and then increase if needed. Again, regular monitoring, so increased monitoring becomes very important at 3, 5, 7 to 8 hours after the meal to ensure that there is no hypoglycemia. You do a dual wave bolus. It could be the 60-40 for some people, a 50-50 or a 70-30. Again, it's very, very individualized and you can split it over 2 to 3 hours. Careful with increase in insulin dosage, especially when the person is having activity or alcohol consumption. So high fat, high carb meal, postprandial hypoglycemia, we see up to 4 to 5 hours. So therefore a dual wave or a combination bolus, which is 60-40 or 70-30 delivered, which is split over 3 hours. And that is available in the pump. Now, for example, if you're having a pizza, so if you're having 3 slices of pizza, regular crust, giving you 80 grams of carbs and 30 grams of fat, I would add 20% to this. So basically I add 20% to 80 grams, which makes it 96 grams. And I will do the insulin to carb ratio for the 96 grams of carbs and then split the bolus dose into 60-40, that is 60% upfront and 40% over 2 to 3 hours. Again, with the new advanced hybrid closed loop systems, like the 780G, and we have quite a few of our patients now on the 780G, the basal increases automatically. So you really do not even need to do the dual wave or the square wave bolus. It takes care automatically. Again, like I mentioned, it varies from meal to meal, it varies from individual to individual, and it varies from day to day. And honestly, every day we learn from our patients, and each individual is so different, and it has to be customized to that person. This is a 16-year-old girl who was in the 780G, and she actually was referred to us because she's constantly going into hypoglycemia in spite of being on the 780G. And if you look at the A is, after she consulted us, and this is A, so she was going into hypo, and her father was extremely worried, and we realized that the mother was actually calculating extra carbs. She was worried about hypoglycemia, and therefore she was actually estimating extra carbs and feeding in extra carbs. And as a result of which the child went into hypoglycemia. So if you look at her carb content, she's been eating the same amount of carbs, the same amount of meals roughly, but her bolus dose has gone down. And therefore, we were able, later on, we were even able to achieve 100% time in range. Her time in range went up from 78% to 81% with negligible hypoglycemias. Again, this is a 21-year-old boy on the 780G. If you look at his, his time in range has gone up. And this was the message that I received from him that, because he was extremely uncontrolled. In fact, his HbA1c was really high. His mother was extremely worried. And then he got onto the 780G. But again, patience is the name of the game when you're on the 780G, because it takes some time for the pump to understand. And it's got its own algorithm. And you should not really interfere with that because, otherwise it becomes extremely difficult to manage. And, after a few months, I received this message from this child that his HbA1c was 5.6 with no major hypos and is extremely happy. So to summarize, I think it's very important. It calls for a multidisciplinary team approach. That is the person with diabetes, the caregiver, the physician, the qualified dietitian, because again, very important is to have a dietitian who understands management of type 1 diabetes, an educator, and I think psychologist, because there's a lot of, this fear associated with food as well. We start with healthy eating. Very important is first to focus on the basics. We do not start with carb counting on the first day because, for the parents, it becomes very overwhelming. It becomes too much of information overload at a time. And then gradually step it up, go on to carb counting and then go on to the other aspects. And that ways we see that the parents understand better. And it's a continuous education that you have to give. high fat and protein requires more insulin, especially when they're eating out. We ask them to experiment and we tell them to make notes. So basically feed in the log as to what they've eaten, how much have they bolus, and, how has it worked for them and what they could do better the next time. Or if it's worked for them, yes, then you just copy paste the next time. High GI meals, early pre-bolus or super bolus on a CSI. And like I mentioned, there is not a one size fits all. So thank you so much for your patient hearing. And this is the team that works very closely with me in managing our children with type 1 diabetes. Thank you.
Thank you. Thank you, Cheryl. That was wonderful and truly exhaustive and comprehensive at the same time. And I think the audience and anyone who's listening, including all the specialists, would understand what a person living with type 1 diabetes goes through. I mean, when they say this is not rocket science, this is probably is rocket science here. Okay, so going from the very basic to the very complicated, Dr. Sujoy, my first question goes to you. And you took us very beautifully through very simple SMBG patterns and all the high suspicion index that we should be having, and they can pop out when we are trained to see with our, the more we see, the eye is trained to find the problems. But I noticed that these were readings which were reasonably few in a week, right? So my first question is that if we are talking about people who have less number of strips, I'm assuming these come from your district hospital children and they have less supply of strips. So have you observed, maybe anecdotally or as a study, that is there a kind of pattern in SMBG which works best in, say, if you have only 50 strips in a month, say you have only 100 strips in a month. So what would be your recommendation for SMBG pattern?
Right. One of the things I think we are essentially making a compromise. Let us accept that reality.
Yes.
We don't live in a country where we will be able to do readings 5 times a day, number one. And even the ones who can afford, I have struggled in my corporate clinic to try and get them to get so many readings. Now, the AGP perhaps helps, but that is probably also helping when things have gone wrong and you're trying to get things back on track. But it's not something that I can get somebody to use 365 days a year. So whatever form of monitoring we are talking about a compromise. So in terms of the SMBGs, when we have about 50 strips a month for our kids, I make sure that they have at least one test a day. I keep a backup of about 5 to 6 of them at least for the bad days, either a hypo or something's gone wrong, or they've eaten something and they want to know how bad was it. So things like that. But I do realize, and I think this is something that, during writing of the guidelines, we had a struggle.
Right.
We wanted to put in 100 at least.
Right.
So if you look at the ISPAT guideline, there is for a minimum basic, there's an intermediate care, and there's an absolute care. So we are somewhere in between. It's not the minimum, and it's closer to the intermediate kind of care that we are thinking of. Now, that's a compromise, like I said. But if we can get the government of India to start off there at least, and then we can, because the first thing one bureaucrat is going to do is going to calculate the cost and say, this program is a no.
Yeah.
So that's the reason why I kind of thought of that 50 strips. Now, one of the things that we've always been taught in diabetes is fix fasting first. Having said that, unlike in type 2 diabetes, fixing the fasting in type 1 is not easy at all. And there again, I am not using, the relatively better analogs. Glargine to me is good enough under the given circumstances. It's at least better than NPH. Number one, you're not having to go for a split mix, one shot, because that at least reduces one shot. And if you look at the numbers needed to treat or harm of Degludec versus Glargine 300 versus 100, the numbers are not that, the difference is not that big. On the other hand, if I could use that money or the resource to get someone like, the clinical psychologists, the dietitians, and others to come on board and help us out, I think we'll be investing better in terms of a public health policy. So number one, I said, check the fastings and try and fix that first. And then I usually tell my kids to maintain 2 separate logbooks. One for the days that they go to school and the one for the day that they don't go to school. Because usually the pattern or the lifestyle is entirely different on the 2 days. So the dose adjustment and the monitoring is different for the 2 sets of days. And accordingly stagger the readings. So if you looked at pre-lunch today, look at post-lunch tomorrow. If you looked at pre-dinner today, look at post-dinner tomorrow. Having said that, this is much more predictable in type 2. In type 1, unfortunately, this is all over the place. And what I presented today is only the tip of the iceberg, the bit that I understood of what goes wrong. The rest, I think we all have to agree, with limited resources and even with the best of resources, type 1 is a difficult game.
Oh. So I was also asking because many of the Western guidelines and overall do not talk about the postprandial blood sugar levels a lot. And in our Indian scenario, of course,
It's very important.
It's very, very important that in type 1, because I get a lot of referrals where I see a chart where only the pre-meals have been advised, and as per that, a dose titration has been given. So I wanted to bring that point out.
So that's one point, it's irrespective of type 1 and type 2s. In an in-hospital setting, I look at pre-meal.
Correct.
In a post-hospital, post-discharge OPD setting, my post-meals are a greater indicator to tell me whether I'm achieving tight control.
Right. So that's a point I wanted to bring out. And on the same note, Cheryl, without monitoring, how would we, so these are two things which are going hand in hand, right? Again and again, you were talking about the nutrition aspect, but you were always saying that we can titrate better when we have a SMBG or a CGMS. So if we do not have a SMBG CGMS, we somewhere fall short of trying to do a very good nutrition plan. So one question I had for you was, you talked about balance, you talked about glycemic index. Does the sequence in which it is eaten can help in?
I mentioned that actually. I spoke about the food order. So basically,
Can you tell us more about that?
Yeah, so basically having protein and fiber. So starting your meal with protein and fiber and then moving on to the remaining part of the meal does help to blunt the post-meal blood glucose response. In fact, the study was done by my friend Dr. Alpana Shukla in the US, and it has really helped and we've seen it. It has definitely impacted, when in our clinical practice and we ask patients, and very easy to implement, right from telling them what not to eat. I think today telling them, okay, how much to eat and how to eat, it has really brought about better compliance as well. So, we tell them, suppose there's a piece of egg, or if there's chicken, or if there is dal, or if there's curd, first have that, have the salad or the vegetable, whatever is there, and then move on to the remaining part of the meal, and that gives satiety as well as it helps to improve your blood glucose levels.
So we have lots of questions. I think these are from people with type 1 diabetes in the chat box. And most of them are about asking what can they eat, which is something we know is very interesting. But they want to know what can be done in an evening snack, because that is the most tricky part. And saying to have 3 meals to a young person is very difficult. So I have girls who have evening snack of pani puri, but they calculate the carbs, and then they stand in front of the pani puri wala. They will calculate, they will have their dose, then have the pani puris.
And the sugars are good also.
And sugars are good.
Enjoy the pani puri.
Exactly.
I think it has a lot to do with emotions as well, ma'am,
Yes.
Typically, we've seen they've gone for a birthday party, they've had a good time with friends, they're happy. And that also, I think emotions also play a big role, So that, yes, like we have to educate them on how to have the pani puri, how to carb count, but we do give them a lot of options in the evening. I think the whole idea is to give them so many options that they do not think of what they can't eat. So that is the most important, because parents are very, very confused, because all that the child is eating is a packet of biscuits, or, eating bread with jam and butter or something like that in the evening. So giving them those healthy alternatives. And I think, again, we have a lot. So we give them chana chaat, or we give them a chilla, or, if they are affording, again, affordability becomes very important. So, we see patients in our clinic, even from very low socioeconomic, like today we had somebody who's delivering cylinders to houses. So, again, for them, you can't tell them to have almonds and makhana and all of that. That becomes extremely expensive. So I think considering the economic status also is important. But there are a lot of healthy options that we can give. If it's a Gujarati, you can look at khandvi, you can look at a chilla, you can look at a chana chaat, you can, do an egg chaat. just boiled egg with something. So that it also gives them satiety. It also depends on whether they're taking insulin. We would encourage them that if they want to eat a good meal, then they need to take that dose of insulin, because otherwise, they're often wanting to take lesser doses of insulin, and therefore they also are looking at options which do not have carbs. So we can give them both the options, and then the child can, the parents can decide what to do. But there are a lot of options.
Right. So I think what you're saying is that they have an option between being willing to check, take an insulin dose, count their carbs, and accordingly eat, versus have a very specific, very low carb snacks or protein snacks. And I think
instead, like they can even take a fruit and go down to play.
And
exactly. Sometimes most often they do not need to bolus for that food, even if it's a banana or a mango, whatever is in season. And we typically see that when they come back, so the play helps, and actually we tell them even exercise works like insulin. So please go and play. And sugars are very normal when they come back.
Because in case of the low resource setting, as Dr. Sujoy showed us, it would be ideal to tell them that this is the evening snack you can have. And maybe, as you said, if they play, do a pre-dinner sugar and see if that worked for you. Even if you do it twice and it worked for you, then it would be a good to go. Right. Coming from that, Dr. Sujoy, you gave us a very interesting insight into HbA1cs. And often we get lab reports, and many times people don't even look at the graphs. Right. And this was such a different variety of. So can you walk us through, say, a clinician looking at a HbA1c report? Can you sort of walk us through what 1, 2, 3, 4, how should we look at it? Because that is very, very important, what you just showed us.
Right. Just an anecdote, one of my seniors actually said, when the patient comes, if you don't look at the graph, the patient gets annoyed. ये test भी किया था मैंने. So just if you have to look at it, the first thing look at it is it actually an HPLC reading? Because you'll get another kind of graph, which is a low performance liquid chromatography. So first of all, make sure that the graph looks like the ones that I've shown. The curve looks like that. So that's a high performance liquid chromatography. There are other kinds of graphs which are actually not high performance liquid chromatography. That's number one. Number two, look at what machine was used. Because machine to machine, the variants are being detected in a different manner. Because of paucity of time, I actually skipped through things. Each machine, you can find out about it on the NGSP website. It tells you which of the variants interfere with the assay, which of them don't interfere with the assay. I had from other machines as well, for example, Tosho and things like that. I did not show it because in India, Biorad D10 is the commonest machine that's used. That's the reason I brought it up. The other advantage of the Biorad D10 is because it's got two modes. Once you have a variant, you can go for the variant window mode, which tells you what form of hemoglobinopathy that individual has. Right at the bottom at the box, it'll tell you A1C is whatever. So if you find that the A1C is something like 0 that I showed you, or 2 or 56, straight away there's something wrong. Then you try to look at two things. A0, that is what is your normal hemoglobin. That should be above 90% on an average. If that's not there, look if there is a variant window that is stated there. Normally in you and me, there will be no variant window. So straight away that tells you it is not detecting a detectable hemoglobinopathy. The next thing that you look at is what is the labile hemoglobin. It'll say LA1C and it'll say CBA1C, that is carbamylated hemoglobin. So because of paucity of time, I didn't talk about labile hemoglobin. Now, if you look at glucose, and when we talk about glycosylated or glycated hemoglobin, we're essentially talking about a glucose moiety binding to a protein moiety, and creation of first step is called a Schiff base, if you remember our chemistry days. And that gets converted to an Amadori base. The Amadori compound is what we are measuring. Now, if somebody's blood glucose has suddenly gone up or suddenly gone down low, then the labile hemoglobin will also go up. So, for example, somebody's had a very high blood glucose level, and then you are measuring the A1C. This glucose might have gone up because you've given steroids. It'll increase the amount of labile hemoglobin, A1C. So the labile and the carbamylated should be less than 4%. If it's above 4%, it'll interfere with the assay. The fetal hemoglobin, which is because in all of us, we have a bit of fetal hemoglobin. But that's usually very little because it's the alpha 2, gamma 2 hemoglobin. But if it's above 10%, even that will interfere with the interpretation of the HbA1c. And I said conditions like severe hypertriglyceridemia, conditions like bilirubin more than 20, they will interfere with the assay as well. And remember that the drugs, clinical conditions that interfere with A1C assays that I've talked about, most importantly, we forget when there's blood loss or anemia and things like that, where the red blood cell lifespan is changed. I'll give you a very simple example. Hypothyroidism reduces RBC cell turnover. Hyperthyroidism increases RBC cell turnover. And even correction of hypothyroidism or hyperthyroidism will change the A1C by 0.4, which is a lot. We don't even think of it. So, just looking at that report and thinking that that's the be all and end all of what's happened in the last few months is not the truth.
Absolutely perfect. One just thought came to me that the variants you were talking about in patterns, one is the menstrual cycle in girls. So in our clinic, we ask them to put the red dots on the days because, again, that is a pattern which is very regularly seen as variating in dose requirements. So on that note, because we have just 5 minutes left, I have a question for both the speakers, and Dr. Sanjay Agarwal has asked this question that, okay, when you have a very highly educated person who has all the best medicines, we know that we can finally get near to the best. What is a thumb rule from both of you? Give us a thumb rule for a child and an adult separately. When the resources are limited, what can be done? I don't like the word minimum care level because I feel at least the intermediate care level should be the minimum care level anywhere in the country. So what is it that they can do which will give them at least a good growth care, prevention of complications, all our targets?
We need a good team.
Okay.
That's number one, that's the minimum basic that you need. You need a good dietitian, nutritionist, good diabetes educator, a patient doctor, not so impatient like me, who's just, has to spend more time. And of course, everybody else on the team. I am happy even with glargine and human regular insulin.
Right.
I'm happy even without an insulin pump. I'm happy even without an AGP or a CGM. If I'm able to teach the child basics of carbohydrate counting, basics of how to adjust in terms of the physical activity pattern, monitoring, and, empowering the child. The quicker you empower the child, the better is the outcome. The mother, there's a definite pattern that I at least see. The father is the person who's most worried in the first few weeks because he's thinking that this is someone that I'll have to support economically and otherwise. After the first month or so, father is nowhere to be found. He's disappeared. The entire stress is on the mother. Now the mother revolves around everything about the child and tries to protect the child. The child is not bothered. Child is playful, taking the insulin, happy to go and show the new toy, the glucometer and the insulin syringes. It's the adolescent days that the child becomes the rebel. So, we've got to think of bits and pieces in each step of that journey, rather than saying, if I give somebody a pump and if I give somebody a CGM or a closed loop pump, that everything is going to work. It's not going to work.
So I second that. And as we all know that in rural areas, we do not have a team. You said a team, but there is no option. Whatever you have in lack of funds or anything can be compensated by education and empowerment.
Right.
So we have to create a team. You create coaches, you reach out.
It's
online.
Difficult. It's difficult. I'm struggling, and I want other people to tell me what works best. What I have recently, been trying to do is do as many camps as possible, because on a one-to-one, I am struggling and I'm incapable of, motivating people to actually deliver the kind of care that people should deserve. And one of the things that I've thought of is creating chatbots and apps,
which could help. True.
Which could help, because that's the only way that I think, because a lot of them have smartphones. I don't know how they can afford that, but a lot of them do have smartphones. So
Any
that's...
comments? Yes, thank you. Any comments, Sharon?
Ma'am,
What
I
do you
think it's, with them, there are very limited food options.
Hmm.
So it becomes, you do the maths, you do the carb counting, you give them, and they, will stick to it because breakfast is very limited. They'll have poli
Rigid.
bhaji or something very. So in fact, with them, I would say in terms of diet, it doesn't really go haywire because then they're not ordering in food or not eating the pizzas and the burgers, etc., etc. So it's very restricted to what is available, and they will listen to you. But yes, there's a lot of time that we need to spend. In fact, we actually call them to the clinic. We spend 2-3 hours with them. The team will do that. We handle them, and as Dr. Sujay said, you have to have a lot of patience with them because you have to try and, the parents are always worried about the cost, the economics. So maybe getting them the funds, where they could get taken. I mean, today you have a lot of those resources that are there. And we also support these kids, with strips and whatever is required, that is there. So at least that thing is removed, that block, in terms of what is the cost that is going in. And then simplifying it for them, I think that really works well. And in fact, they do better. And we always have some other parent who's there guiding them. Like you've made those, you have the
decots, yes.
So that's wonderful because sometimes you don't have that bandwidth at the time, but there is somebody else who's there guiding and each one having a mentor that really helps. And in fact, they pick up so well. And I'm amazed to see that the way they pick up. It's amazing.
Thank you, Cheryl, and thank you, Dr. Sujoy. And I think I will conclude by saying whether it's monitoring or it is medical nutrition therapy in a person with type 1 diabetes, it is the education which is going to make a difference, even when everything is available or minimum resources are available. And as it was pointed out, we don't have teams. Definitely digital is one way to go. Other way is, for example, as Cheryl mentioned, I have a program called Mighty Mom. So we trained mothers of children with type 1 diabetes in a structured course where they became coaches. So today I have a team of 30 coaches who are able to deliver basic diabetes care. They may not be able to do carb counting, but all the basic care, all the way from site rotation, reducing the lipotrophies, everything else is something they can teach. So we have to find innovative solutions, but education is the bottom line. And that is why it is so individualized and so tough to treat. Thank you so much. Thank you, everyone who has logged in. And thank you for our wonderful speakers. It was a wonderful session. Thank you.
Thank you very much, Sujay. Thank you, Cheryl.
Thank you, sir. Lovely seeing all of you. Good night, everyone.
Good night. Bye-bye.